Good day. My name is Michelle Lavander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, What the South Tells Us About Medicaid's Future. Our country will soon witness an era of unprecedented rollbacks in health coverage that could bring big cost savings to the federal government, yet put health coverage at risk for millions of Americans. As a result of these changes, Americans will have less health insurance, less access to health care, and higher medical debt. As we try to understand what lies ahead, states in the Deep South can offer a window into an uncertain future for many more Americans. The Deep South includes 7 of the 10 American states that never expanded Medicaid, the health insurance program for low-income individuals and families. Not coincidentally, those Deep South states have some of the worst health outcomes, greatest health disparities, and shortest life expectancies in the country. The changes were triggered by the president's signature last July to the One Big Beautiful Bill Act, famously introduced by the Republican administration to end waste, fraud, and abuse. Policy analysts say the legislation will result in the largest Medicaid cuts in the program's history, with an estimated 10 million more uninsured people in America by 2034. So, what does this mean for the health of vulnerable Americans? Will families be able to find a clinic that can provide prenatal care anywhere near their rural town? Will new mothers be forced to weigh the benefits of therapy for postpartum depression against the risk of a pile of new medical bills? And what happens to rural hospitals and clinics already struggling to keep their doors open? Already, according to reporting by one of our panelists, journalist April Simpson, many uninsured residents of Deep South states, quote, avoid doctor's visits until it's a life or death scenario. The healthcare stories of the Deep South have a lot to teach us about the coming months and years as funding cuts and work requirements take effect. Today, we're fortunate to hear from a distinguished panel, 2 reporters and an advocate, who will share their deep experience with the struggle to get and afford care for ordinary people in states across the South. We hear from April Simpson, an independent journalist based in the Houston area. Previously, she served as a senior reporter covering racial equity for the Center for Public Integrity. April was a 2025 Pulitzer finalist for her contributions to the Center for Public Integrity Project, 40 Acres and a Lie, a historical investigation into how formerly enslaved Black Americans were given land and then unjustly stripped of it. She was previously the Rural Issues reporter at Stateline. She was a U.S. Fulbright Fellow in Botswana, Eastern Democratic Republic of Congo Fellow with the International Women's Media Foundation, and Innovations in Food and Agriculture Fellow with the National Press Foundation. Simpson is a graduate of Smith College and the London School of Economics and Political Science. We'll also hear from Roy Mitchell, the Executive Director of the Mississippi Health Advocacy Program. His 35 years of public interest advocacy experience has included overseeing legal clinics for domestic violence victims, low-income housing tenants, ACA marketplace consumers, SSI disability appeals, Medicaid appeals, and more. He has organized several statewide coalitions and initiatives and successfully helped shape Mississippi health and welfare legislation. He served as the consumer's representative on many Mississippi Medicaid and insurance committees and task forces. He's a native Mississippian and a graduate of the University of Mississippi. We'll also hear from Anna Claire Vollers, who covers healthcare for Stateline and is based in Huntsville, Alabama. She's been an Alabama reporter for nearly 2 decades, covering health, education, politics, and social justice. Her work has won state and national awards, including the Society of Professional Journalists Sigma Delta Chi Award for feature reporting in 2018 and the 2017 Story of the Year from the Alabama Associated Press for her investigation on religious boot camps for teens. She previously reported for AL.com, Alabama's largest news site, and the Birmingham News. She was also a 2018 Data Fellow at the Center for Health Journalism. Her project with us investigated child deaths and injuries in Alabama. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format. We'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Feel free to share any technical issues in the Q&A, And because we have many people joining us, we'll ask you to write your questions for our speakers in that panel and to let us know of any technical difficulties. Now let's get underway. April, starting in 2014, the federal government has provided generous subsidies to states that expanded Medicaid to people with incomes up to 138% of the federal poverty level and to adults without children who had long been excluded from the program for low-income individuals and families. To date, 40 states and DC have adopted this Medicaid expansion, while 10 states have not, many in the Deep South. You did seminal reporting on what it means to ordinary people in healthcare clinics and hospitals to decide whether to expand Medicaid. You compared two counties on either side of the Mississippi River, one in Louisiana, a state that expanded Medicaid, and one in Mississippi that didn't. Tell us about what you learned about some of the key differences you found when it comes to healthcare coverage and access to doctors, and how did you translate that key policy gap into human stories?
Sure. Well, thank you so much for the introduction, and thank you so much for the opportunity to be here. I want to talk with you about a story I did for Public Integrity that focused on the Medicaid program. I spent a lot of time interviewing experts, officials, providers, and people to understand the system, its historical roots, how it's changed over time, how it operates, and is experienced at the state level. So let me break it down with the examples of two men. Gabriel Muhammad is a 40-year-old self-employed carpenter and plumber in Jefferson County, Mississippi. And Alvin Brown is a 46-year-old man who stocks liquor and wine for retail outlets in Madison Parish, Louisiana. So they're two men of similar age. They live miles from each other, but on opposite sides of the Mississippi River. But when each faced a medical emergency, one had his bill largely taken care of, while the other was having to pay his bill off bit by bit. What's the difference? The big difference is that one lives in a state that expanded Medicaid coverage and the other lives in a state that has not. What does that even mean? I want to back out a little bit and just do a little Medicaid 101. It's a partnership between the state and the federal government. The program matches federal dollars to state money to provide health care to the most vulnerable. Federal law mandates that states cover certain qualified low-income groups, such as families, people with disabilities, seniors, pregnant people, and children. But the state ultimately decides who else is eligible, often by using a specific percentage of the official poverty level as a requirement. Since the program was created in 1965, it's grown to become the largest health insurer in the country. The seeds of the safety net program were in civil rights legislation that sought to advance economic, legal, and political rights of Black people. And in President Lyndon B. Johnson's Great Society, which was this massive social reform initiative that sought to end poverty, among other things. Healthcare was a critical part of combating poverty. Initially, the government had considered a federally run national healthcare program to serve vulnerable populations, but Southern politicians who opposed civil rights legislation and shaped federal health policy opposed this legislation. So administering Medicaid as a state-run program was a political compromise that paved the way for the geographic and racial inequities that we see in the program today. So what is Medicaid expansion? When the Affordable Care Act was passed, it required states to extend Medicaid coverage to all childless adults up to 138% of federal poverty line. Medicaid expansion was designed to reduce racial and geographic inequities in health insurance coverage. The expansion also sought to create a national standard. However, that didn't happen. In 2012, the Supreme Court decided that participation could be made optional for states. Now we have 40 states plus Washington, D.C. that have expanded Medicaid to cover everyone up to that 138% federal poverty cutoff. The Affordable Care Act provides subsidies to people whose incomes are between 100 and 400% of the federal poverty level. And states that expand Medicaid cover adults with incomes up to 138% of poverty, or just under $37,000 for a family of three this year. A 2012 Supreme Court decision gave the states the option to decline to expand eligibility, and that decision fell largely along partisan lines. So it left what came to be called a coverage gap, where some people were too poor to qualify for the health insurance subsidies the ACA made available, but not poor enough to be covered by Medicaid under state guidelines. So back to Gabriel and Alvin. One had their medical bill largely taken care of in an emergency, while the other was still paying his off bit by bit. What's the difference? Gabriel in Mississippi had an income of no more than $10,000 a year as a self-employed carpenter and plumber. He was hit with a $1,400 hospital bill for an MRI scan to diagnose why he wasn't breathing properly. And he got stuck with that bill because Mississippi hasn't expanded Medicaid. That means single adults without children, like Gabriel, are not eligible for public health insurance, regardless of how little they earn each year. Whereas Alvin Brown in Mississippi was able to get help. He started feeling bad, his back hurt, it was painful for him to go to the bathroom. He was dehydrated, and as a result, a kidney began to malfunction. He was eventually admitted to a hospital nearly an hour away from where he lives. Alvin had an annual household income of $28,000 for a family of three, which put him under the threshold of earning 138% of federal poverty to qualify for Medicaid coverage. And being enrolled in the program saved him from paying $7,000 of a $9,000 hospital bill, which is basically a third of his income. So these stories are important, but so is the data that shows why these stories are examples of a larger context. Because there's so much data, we wanted to point to the most important data points and try to humanize that data by focusing on Gabriel and Mohammed, or excuse me, Gabriel and Alvin, but also their larger communities. So Jefferson County and Madison Parish, to some extent, became characters in the story. I wanted to show that beyond what was happening with Medicaid at the state level, these were two demographically similar communities with similar histories that derived their early wealth from slavery and the plantation economy. They're both among the poorest and blackest counties in the country, and they both happen to be named for former presidents and slave owners. But because of Medicaid expansion, healthcare access looks very different in these two places. Prior to the Affordable Care Act, more than 20% of adults younger than 65 in both counties were uninsured, and then their paths diverged. In Madison Parish, the uninsured adult population plunged about 8 percentage points, while in Jefferson County, it stayed about the same. Gabriel and Alvin have really important stories, but how do you even find people like them? It can be challenging to find people who are willing to go in depth on their medical histories, especially when we're talking about finances and debt. So you can find people through advocates, you can find them through trusted sources who can make introductions, which is how I found Gabriel and Alvin. So in closing, I just want to quickly offer 10 tips on how to approach these kinds of inequality stories. One, become an expert in the system. Medicaid is really complicated, but there are plenty of resources out there from places like the Kaiser Family Foundation and the Center for Budget and Policy Priorities, who write about Medicaid in a very digestible way. Two, how do systems and experiences compare between states? There's a lot of opportunity to do reporting on federalism and racial inequality and how federalism can disadvantage people of color and why. Three, what are the historical roots? The Medicaid program was birthed in 1965, which was this critical year for healthcare and also for civil rights. I included this photo because it's important to think about historical roots at the local level too. So this is Main Street in Fayette on December 4th, 1965, where they had organized a quote, Black Christmas march to boycott local stores until officials met with some demands. At the time, Fayette, the county seat of Jefferson County, was majority Black with all white leadership and no Black folks registered to vote. Four, show disproportionate impact. How is the group you're reporting on different from other groups? And five, choose sources who are the best examples of the program. That goes back to the knowing the system. Six, use data where it counts. Try not to overwhelm your reader, but make it digestible and put it in terms that the reader can understand. Six, build trust with sources. Or sorry, seven, build trust with sources. Eight, explain the process, especially when you're dealing with folks who aren't used to working with media. Nine, consider your audience, or sorry, report from the field if possible. Soak up the color and people will feel more comfortable laying eyes on you. And then lastly, consider your audience. What are the best tools and platforms for the reader to understand and access the story? And we distributed this flyer that you can see here because there was very poor internet access in Jefferson County. So thank you so much for your time. Feel free to get in touch and I'll pass it on to Rory.
Thank you so much. Let's turn to Roy for a moment. We just heard from April on how people in one Mississippi county have struggled to afford the care they need far more than their neighbors living in an expansion state. And as a longtime healthcare advocate in Mississippi, what has been your experience of living and working in a state that has not expanded Medicaid in terms of patients and the healthcare system? And what should the rest of the country learn from your state story right now?
Well, and thank you, and good afternoon, everybody. Yes, Mississippi's failure to provide affordable health care for working adults shows up in our state's healthcare outcomes. And frankly, our state isn't getting any healthier. Our economy hasn't reached its full potential, and our rural hospitals are currently struggling to stay afloat. Mississippi has the second highest share of adults with medical debt, and this will only worsen with continued inaction on Medicaid expansion. Each year, our state is losing out on billions of dollars by not expanding Medicaid, and our families and hospital systems are bearing the burden for not expanding. And this decision, it doesn't just impact our state's uninsured population, it puts every Mississippian at risk. Just a few stats here. Recently, in a survey conducted by the Commonwealth Foundation, Mississippi's health system performance scorecard was the lowest in the nation. That was just this month. 15.2% of Mississippi adults owe money for healthcare services. 40% of Mississippi adults under 65 have medical debt. And the leading cause of bankruptcy in Mississippi is in fact medical debt. We generate a huge amount of uncompensated care, 600 million a year. If we expanded Medicaid, we could cut that to a third. We currently have 200,000 Mississippians in the coverage gap. And more recently, just last month, the state health department declared a public health emergency due to the infant mortality rates in Mississippi reaching a 9.7 death per 1,000 births. This is the highest it's been in 10 years. Since 2014, more than 3,500 babies in the state have died before turning 1. Mississippi also has the highest maternal mortality in the nation with 26 deaths per 100,000 live births. Over 80,000 of those deaths were deemed preventable. So as you can see, Mississippi inaction has resulted in a lot of cost, a lot of human suffering. And we're looking at even more uninsured coming to the rolls with the expiring premium tax credits. Like a lot of states that haven't expanded, Mississippi relies very heavily on these premium tax credits to give our residents coverage. In fact, Mississippi has, it's predicted that the largest percent of increases in the uninsured will be in Mississippi at potentially losing 43% of coverage in the ACA marketplace, which is currently forefront in the news and the congressional budget debate right now. Looking at Mississippi's history, and as has been noted, I've been doing this a long time. Back in 2024, we had Haley Barbour, who was at the time or recently had been chair of the RNC, ran for governor of the state on a Medicaid reform platform. He made the argument that by cutting Medicaid, he was protecting services for the most vulnerable in the program. Well, Haley Barbour made good on his promise to do that. In his first year in office, he cut 65,000 Mississippians from the Medicaid rolls. The public outcry was huge. And journalists were very much involved in that, documenting the stories, covering community meetings. And as a result of that outcry, those cuts were reversed in the next legislative session in Mississippi. So, we say here, so goes Mississippi, so goes the nation. And journalists can put in this if these cuts move forward.
Thank you, Roy. What a sobering picture. Very, very helpful. I want to turn to Anna Claire. You've reported quite deeply on how the lack of Medicaid expansion in the South has rippled through the lives of families in vulnerable communities, shaping pregnancy outcomes, mental health access, children's health, and community well-being overall. How have you gone about translating those complex policy shifts into real-world impacts and human stories?
Thanks, Michelle. I am glad to be here. Make sure you guys can see this. So I want to talk about one story that I did more recently. So I've been covering Medicaid policy in Alabama for a long time now, and it can be really complex and kind of boring for readers. And so one of the easiest ways that I like to cover it is to explore its impact on a really specific, particular group of people, kind of like April mentioned. And so one thing that I like to do beyond looking at the usual groups of folks who can't get coverage are looking at how our refusal to expand Medicaid impacts even the groups that the state has decided, quote unquote, deserve coverage. So like pregnant people, children. And I feel like this helps bring accountability and clarity when we hear officials say things like, they're cutting Medicaid so that only the most deserving people will be able to have it. As we all know, nothing happens in a vacuum. Healthcare does not happen in a vacuum. And when you make cuts for some people, you are making cuts to whole families, and there are ripple effects. And so I did a story earlier this year looking at maternal mental health care. So even in states like Alabama that haven't expanded Medicaid, if you are pregnant, you are able to get Medicaid when you might not otherwise if you weren't pregnant. So it is extended to people who make a little bit more money because they're pregnant. And in the last several years, even non-expansion states have extended pregnancy Medicaid through 1 year postpartum, with a lot of our officials and legislators really bragging about this, that they've made healthcare available to new moms, new parents for up to a year after the baby's born. But what I learned as I was talking to providers and to people trying to access mental health is that while on paper, Alabama Medicaid does cover mental health treatment for new moms, because of the way that our state chronically underfunds Medicaid, that mental health care is almost non-existent when it comes to the reality of a person who just had a baby trying to access mental health care for something like postpartum depression, for anxiety, and those kinds of things. And this is a big deal because mental health conditions like suicide and overdose are the leading underlying cause of pregnancy-related death, and they impact entire families, entire communities. And so that was one example of looking at not just the folks that you think are immediately impacted by loss of coverage, but even the ones who have coverage. When you cut Medicaid in the way that is going to be happening, that impacts everyone. One tip I would say is when you are talking for reporters, when you're talking to providers like doctors and nurses, counselors, ask them really specific questions about the kind of reimbursement that they're getting through Medicaid. I know that sounds boring, and this may not be a thing that you have to explain to readers, but that will help you understand how that is affecting their ability to provide care. Because asking, for example, Dr. Friels, the lady in the bottom corner here, asking her about that helped me better understand why almost no, very, very, very few counselors are able to provide mental health for new moms because of the problems with reimbursement from Medicaid. April touched on this, and I'm really glad she did. And, here in the South, we do love to talk about history. But I did a story recently because this year was the 60th anniversary of Medicaid. And it also happened to be a really big year for civil rights. It was the 60th anniversary of the Voting Rights Act, of the Selma to Montgomery March. And so I wanted to look at both talking about something that I think not a lot of people, unless you've read excellent stories by folks like April, understand, is how closely Medicaid and this push for universal health care was baked into the civil rights movement. And so I took some of that history and wove it into a story about modern grassroots efforts to improve healthcare in the same towns and the same communities where some of these the fiercest battles in the civil rights movement were fought 60 years ago and more. And one thing that I really dislike about a lot of stories about Alabama's Black Belt region and some of our counties that were really like the ground zero for the civil rights movement is that a lot of times stories are talking about everything that people don't have there, all of the challenges they face, how terrible it is to get healthcare and all those things. And it's really, really important for all of us as reporters. It's something I've been working on, I think, for a decade or more, pushing myself to make sure that when you're reporting in areas trying to highlight the consequences of bad health policy, of underfunding hospitals and clinics, that you are giving agency to the people who are in those communities, and that you are focusing on the people who are still there doing the work. It's not a victim story, and it doesn't have to be just a feel-good story about somebody doing a great job. The work that people are doing can help highlight this really vast, systemic, and deeply rooted healthcare issues that we find in a lot of communities. And so understanding that history, I think, helps, at least for me with this story, it really helped tie in the people who were doing the work 60 years ago with the people who are doing the work today, and about how some of those battles are different and some of them are exactly the same. And I think that also helps give our readers just a little more context. I'm always surprised at how interested people are in history behind things. I did a story a couple of years ago about the fight in Alabama to legalize birthing centers, which have not been legal here. And one of the stories I did in that whole series was just about the history of Black midwives in the South, and that ended up being one of our most popular stories on the site. And so I would encourage reporters to never ignore the history. Let's see. And finally, when you're talking about human impact stories, Medicaid can be woven into almost every health story that you will find. At least I have found that to be true. I did a story late last year about, it was really a feature about a very small town in Alabama that had been able to build its own hospital a few years ago, bucking this trend of rural hospitals closing. It's a town that's 70 miles from the nearest interstate, and they had really done this amazing thing. And then COVID happened and a lot of other things happened and the hospital closed. And so I did a story about their kind of greedy mayor and the town that's trying to get that reopened. But one line running through that was Medicaid, and Alabama's refusal to expand Medicaid has led to the closure of rural hospitals. I have just found that you can almost always weave a little bit of that kind of policy into feature stories you're doing, into stories that aren't directly related to Medicaid. And I think that overall just helps build a greater understanding with readers about how these kind of esoteric, sometimes boring and complex policy issues impact even areas that they may never have realized. And let's see. Okay, that's the end of my part. Thank you guys so much.
Thank you, Anna Claire. I want to ask all of you to share your perspectives and a few other aspects of the situation we find ourselves in. As you know, Trump recently moved, for example, to block federally qualified health centers, which are the kind of anchor clinics in many communities, from serving undocumented patients. And I'm wondering how that's playing out in your states. Here in California, the Attorney General has sued, but I'm guessing that's not the case in some of the states in the Deep South. And what should reporters keep in mind when covering fears about seeking care and even just access to care in this climate?
I would say, as usual, this is one of the things where having great sourcing will be your biggest, um, will be the biggest, most important thing that you could be doing, especially as we're looking at things that may happen in the future that we expect could happen right now. Is the time to be building those sources. I think particularly in communities that speak a language that you don't speak, potentially, it's always a good idea to start talking now with doctors, with advocates and folks who are doing the work there so that you will be able to, you'll be better positioned to hear about and then report on the stories when they happen.
Does anyone else want to weigh in on that issue of the undocumented patients, and whether you have a sense if they're staying away or being turned away? Well, maybe we'll circle back to that in another webinar. Here in California, the bigger issue is that people are being they're so frightened that they're staying away, and we're seeing a drop in care. And some safety net clinics, for example, are offering telemedicine and even home delivery of prescriptions. But I think the way that different states and healthcare clinics and hospitals respond is really very tied to politics right now. So I wanted to go back to this point about what it means to lose a local hospital or a clinic for the daily lives of people in rural communities. And Anna Claire, I love what you said about trying to like sneak in a mention of that, even if it's not a story that's centered around it. But for all of you, what are some of the best ways to capture those impacts, especially if a hospital's, one of the larger employers in town?
I think one of the ways we can do that is by focusing on the folks that or institutions that help to fill those gaps in care. So, for example, I had the opportunity to spend the day with a midwife when she was making her rounds in rural West Tennessee and Kentucky. And I was able to kind of be a witness to how challenging it can be for pregnant people in those places to access prenatal care. But then also to hear from the midwives about the hostility they say they encounter when they transfer patients to hospitals. So I think just kind of identifying those folks can be a way to capture those impacts.
Anybody else want to weigh in on that one? Roy, I mean, you're kind of coming at this as an advocate, and you're having a lot of conversations with hospital officials. What are they telling you, and what do you think maybe reporters could be paying more attention to in that regard?
Well, we're a very rural state. Roughly 65 out of 82 counties are rural. Over half our population lives in non-metro areas. We have a lot of FQHCs. Of course, there's been a lot of attention paid to the Rural Hospital Fund, and whether it's the community or our legislators, they're very focused on the Rural Hospital Fund, how it's going to be administered in our state. And frankly, it's not going to be enough to support rural hospitals. I think I gave some stats on it earlier. Since 2015, we've had 8 hospitals close in the last 10 years. 60% of our rural hospitals are losing money. And frankly, the amount that's being talked about in the Rural Health Transformation Act is it's going to be like putting Band-Aid on a wound. So I urge journalists to cover that in their states, gather information, commit to doing public information requests on Rural Health Transformation Fund.
Thank you, Roy. And April, I don't know if you want to weigh in on this issue of covering local hospitals. I'm also interested in your strategies for finding the people you featured. You touched on this earlier, but I don't know if there's an example or two that comes to mind about, how you found some of these folks and just were able to paint such beautiful portraits for your Medicaid coverage.
Sure. So, working through advocacy organizations, community leaders is always helpful. I found Gabriel actually when I was on the ground doing reporting And a woman that I was spending the day with basically was taking me around, and she introduced me to Gabriel, and um, that's how I was able to kind of start that relationship. For Madison Parish, I found Alvin kind of through a Facebook group. There's like a very lively community group that I was a part of, and there was a woman who talked a lot about Medicaid. So I reached out to her, and then when I needed to find someone like Alvin, I circled back to her, and she was able to point me to him. So kind of just working your sources has been useful to me.
And Anna Claire, do you have any tips for what's worked for you?
Yeah, I mean, on the ground reporting, you can't beat that. I found when I did the story, looking at grassroots groups working in Montgomery and tying that back through to the civil rights movement. I was on Facebook looking at some healthcare workers that are in the Montgomery area and noticed that a couple of them were part of this group called Girl Trek. And I looked into it, and it was a healthcare focused organization run by and for Black women. And they had just opened their newest outpost in Montgomery in the Bricklayers Hall, which is where the Selma the Montgomery bus boycott started. And that seemed like such a perfect ended up being a perfect group. They let me go on one of their walks with them, but I connected with them that way through social media. So I love trolling social media when you are not right there in the community on the ground.
And if I could just drill down for both of you on this idea of doing Facebook searches, what kinds of terms are you using? And what are your protocols when you find a group, especially a closed group, to get in the door?
I think for that particular group, I'd already talked with like local officials and other folks, so I was kind of known to some extent. I think one of the administrators might have known me. So they actually didn't give me much of a hard time at the point of trying to get in. Um, and then I reached out to people on the sides. I didn't have anything, I don't think, special around search terms.
And how about you, Anna Claire?
Yeah, I mean, if there's a particular thing I'm looking at, you can always search that in the town or the community that you're looking at. I like to look at community groups, and I will message people who have been commenting under posts that look like they know a little bit more what we're talking about. Maybe it's a nurse talking about a local hospital closure on a what's happening in Rainsville post or something like that. And a lot of times I found that people are actually really willing to help, and they don't mind being contacted on Facebook as much because they can see that I'm a real person and they see my profile to an extent.
Yeah, thank you. And I just want to echo what we posted in the chat, which is that we're ready to welcome any of your questions too. So feel free to post them in the Q&A. We have one here from Olga Gabriela Villegas, who says, "Thank you for sharing your tips on how to reach sources. I was wondering if you might also have advice on encouraging people to go on camera. I'm investigating mental health among Hispanic immigrants, and while some are open to talking, it's understandable that many prefer not to appear on camera."
I That's one of the really lovely things about being a print journalist is that a lot of times we don't have to deal with video, but I find and I'm sure you're doing this, but setting up a meeting with the person first in person if possible and talking with them that is completely off record, if that just to help them to feel more comfortable with you and who you are. I like to send people links to other stories that I did that are similar so they can see what my work looks like, and they can hopefully find that my reporting is trustworthy and valuable, and just have a really good conversation about where this will appear and how, and what we hope an impact might be.
And April, did you want to weigh in on that one?
I think everything Anna Claire said is spot on. Just kind of doing a lot of hand holding to some extent, and always checking in and making sure at every point that this person is comfortable with where the interview is going.
And if I can add a few suggestions, one of the things that we've been talking about and thinking about with journalists that we're working with who are doing reporting on a lot of sensitive topics, is to take the time to explain to that person how the interview will work, and maybe just avoid the kind of nomenclature that is only familiar to journalists and, someone at City Hall or, at the Capitol. So it's not like you're off the record or not for attribution or whatever, but just to really explain, like, these are the things you can tell me. Like, you can tell me that you're going to share something and we won't film it and we can turn off the camera, or you don't have to answer my question. This is your story and we want to be respectful, and just to lay out some ground rules that help that person have a feeling of control. And then maybe just, and I'm sure you've thought about this a lot, Olga, Gabriela, but just being able to shoot people in ways that don't reveal their identities, and in settings where you're taking a lot of care that can't be identified, that those things, and just having those kind of agreements can be very helpful. And I think Claire's point about showing them stuff that you've done in the past that has accomplished that, can be really helpful in building trust, and not, coming in with the camera on, but I'm sure that one you have down. So just even also going back to this idea that was mentioned earlier about how you portray people, not just as victims, but as people with agency and resilience. Some of that can be the work with, if you're shooting yourself, or the work with your camera person, the angles that you shoot and the postures that the people have can convey some of those things as well. And then I'm just going to invite other folks to put your questions in the chat, but also just going to ask all of you, a couple more questions. And, Roy, I think, alluded to this earlier, that when there were concerns about all these cutbacks and their impact on hospitals and clinics, there was a measure kind of rustled up that will provide $50 billion in $50 billion rural hospital fund that is supposed to be a cushion against the Medicaid cuts. And that's what Roy was referring to as a Band-Aid on a wound. And I'm just wondering, April and Anna Claire, what suggestions you have on some of the questions journalists should be asking now, and how they can be assessing whether that money will slow or prevent rural hospital closures in their communities.
I'll let Anna Claire take that.
Sure. I mean, every state is going to do this a little bit differently. I've been really interested to kind of read about how, I know here in Alabama, they're having weekly meetings at the state level to discuss how they're going to use this initial outlay. They've got to submit a plan by, I think it's early to mid-November, something like that. I was interested to see that there are a lot of things that the money can't be used on, including like building construction. So we're not going to see like new rural hospitals cropping up out of this. But there are other ways. I would keep an eye on the stakeholders that are involved in those meetings. You're going to see, the hospital association, you're going to see the medical association, and they've all got different priorities that may or may not line up with what communities need, or maybe they do. And so just the who's at the table and who's getting heard when it comes to how the state should be trying to spend that, and also keeping an eye out for hospitals and communities that are claiming rural status, but may end up actually being a little more suburban than what we might imagine as a rural. I think a lot of those definitions of rural are really squishy, and so that will be something to watch out for also.
Thank you. We have a question from Elizabeth Fight, who asks, do you all have any thoughts on whether or not the new Medicaid work requirements might disproportionately impact Southern expansion states compared to other expansion states, or just thoughts about covering the work requirement in general? And I guess I'll ask you all, in answering this, to maybe just take a step back, walk through the work requirements and how they're supposed to work, and why many people think that they'll be damaging to folks who are working, who are supposed to be shielded from all this. Anybody want to tackle that?
So they will be instituting something that Arkansas tried, and actually Georgia has got a plan that operating right now that's a little bit like this, but it will require adults to prove that they are working or volunteering or in school for, I think it's like 80 hours a week or 80 hours a month. Or that they qualify for some kind of exemption, like they're a full-time caregiver, in order to qualify for Medicaid. And a lot of people are really concerned that it's going to kick a lot of people off of Medicaid because of the extra onus on each individual to submit the correct paperwork. I was reading a really good story out of Georgia recently where they had interviewed this woman who's an actual social worker, or was, in Georgia. And so she understands the system. She had all of her paperwork lined up, filed it in order to qualify for Medicaid, and it took 6 months to get through it. She kept getting kicked out of the system, or various issues with her paperwork. It said it wasn't correct. And anyway, so if somebody like that is having an issue, we imagine that we're going to see a lot of other people have an issue. I will also, Georgia's system, when they instituted, I think they started like 2 years ago, they've spent more than $50 million building and operating this big reporting system for people to be able to turn in their proof of work or proof of school. And so that's a huge outlay that they're not spending on, actual healthcare for people. So that's something to keep an eye on, I think. And also, at least in Georgia, they had a really low enrollment. So they've been doing this work requirement thing for like 2 years, and they've only got like 9,000 people in this program that gives them a Medicaid type coverage as long as they can prove that they're working or in school or whatever. So I think I would just look for lower enrollment is what we've seen in Arkansas when they tried it, and what we've seen in Georgia.
And Roy, I'm guessing you have some thoughts on this as well.
Sure. And in Arkansas, they found that 95% of the enrollees subject to the work requirements were already meeting them. And then, of course, Anna cited the cost. I think Georgia, which was when we were still considering work requirements in Mississippi, our legislators were using Georgia as an example, which is a very poor example. First of all, I mean, the first year they only enrolled 4,000 people, and the cost per enrollee was just astronomical. Again, they ran into the same dynamic where the people were already working, yet they still couldn't get enrolled. So in southern states, I imagine you'll continue to see more of that dynamic.
And Roy, correct me if I'm wrong, but I seem to recall in Arkansas that part of the issue was that the way that you would prove things was online, and that for people who weren't particularly agile with online, like older folks and so on, there was no real easy way to do this, say, by phone, and not a kind of well-staffed infrastructure to offer help. And so it was sort of like a bit, people felt like they're in a bit of a catch-22. Am I remembering that right?
That's correct. Administrative burdens that they paid dearly for. I mean, the first year, I think I recall 26 million in the first year that was spent, and largely people lost coverage because of the administrative burdens, like you cited there.
Yeah, and so sometimes these small details, and maybe just following a person through their efforts can help make these bureaucratic challenges seem more real. April, I want to just return to your reporting where you compared the two counties, and just curious how you've gone about selecting making those kind of decisions in that instance. For your Medicaid story, did you start out with a large data set and an analysis that showed two counties with the biggest contrast, or was it just this idea of the river running through it? How did you come up to those lead examples?
Well, I had decided that I wanted to do something, on an expansion state versus a non-expansion state in the South. So I made a big spreadsheet with, Louisiana and its border states that were non-expansion, Arkansas, and so on, and looked for where there were high percentages of uninsured people, uninsured adults that were, near the state lines, and also just not terribly far from each other. And that's kind of how I found Jefferson County and Madison Parish. And then, drilled down further to see that these were both demographically similar and had, similar histories in terms of how they initially built their wealth.
Yeah, thank you. Really interesting. And we have a question from Elizabeth Palmer Jarvis, who says, can you speak to strategies you use to try and fill the gaps presented by the lack of healthcare data being gathered in general? When telling these impact stories, I'm thinking of the example of maternal mortality data, since more restrictions to reproductive healthcare have gone into effect in many states. When the data isn't being gathered or not released or it's not trustworthy, how do you work around those roadblocks to get the information to the public?
That's like a perennial problem, I feel like, in maternal health, at least as long as I've been covering it. To some extent, I mean, I think all of that is like it's like on purpose. I mean, you cannot report what you don't know. You cannot be held accountable for numbers that you aren't collecting if you're an official. I find that when you cannot get the data that you need, experts are helpful, ones that have a great history and are well regarded in that area. But then really this is where the human impact stories come from, because you can't deny somebody's lived experience, and if you can find several people who have had the same thing that is happening elsewhere. And there's some good advocacy groups, I think, that have stepped in the gap. And I know you've got to watch, obviously, when you're pulling data from some groups, but there are some really good groups out there who have been starting to collect data like this in the absence of our state or federal officials collecting things. So those might be another option for you as well.
And Anna Claire, are there some you turn to regularly that you'd recommend in that regard?
It kind of depends. I'm sorry, off the top of my head, I can't think of some. Although if anybody watching this wants to email me later, I'd be happy to send you a few folks that I've relied on in the past.
Yeah, thank you, Anna Claire. And Roy, I just want to come back to this issue of I don't know what happened in Mississippi before, where the governor thought it would help win him popularity to make these pretty severe cuts in who could receive Medicaid, and the legislature had to step in and reverse it to kind of combat an uproar. And right now, many MAGA or Trump supporters are enrolled in the health exchange plans and the Affordable Care Act subsidies that are scheduled to expire at the end of this year, unless there's some sort of congressional intervention. What does that suggest to you about both the complex politics of this policy issue as Congress is debating this, and some of the opportunities for some nuanced storytelling about this kind of circumstance?
Well, you mentioned MAGA. I saw an interview with Senator John Thune Sunday morning, where he was alluding to this MAGA mantra, waste, fraud, and abuse in the ACA. When the cuts hit, we're all going to find out exactly who's being impacted by this. And it's going to be rich with stories of people the program was designed to help. And we have just got to make those stories more pronounced in the media. I've heard this theme today where everyone's talking about, how do I get this data? How do I do this? You've got to leverage these state-based and community advocacy groups. They have the connections to the stories. They work with the communities. They know the eligibility rules. They know exactly who's going to be impacted this. They have built trust with the immigrant community. And I understand that there's a lot of national groups out there that have a lot of data that are very good at it, but frankly, they're overwhelmed right now. I urge journalists to reach out and build relationships with state advocacy groups like ours. We have a consumer assistance program we've had for 20 years. People call us that are having eligibility issues. We have a wealth of stories. And you can build trust with the people impacted through these groups as well. Now, that doesn't mean we can just generate stories, because there is a lot of fear out there. People are reluctant to go on camera right now. but you've just got to find where their comfort level is. But again, leverage your local state advocacy groups to collect the data, to collect the stories, and know how these policies are impacting people, so that we can tell a story that's not just a bumper sticker, how it's really impacting communities.
Yeah, and April or Anna Claire, did you want to weigh in on this at all? This complex situation about the MAGA, folks being most likely to be hit hardest. It kind of reminds me of those pictures that we saw that said, government, get your hands off my Medicare. I mean, we're kind of in an analogous situation now.
Yeah, I mean, even for people who have coverage, they've never had Medicaid and don't know anybody on Medicaid. I think always including a bit in your story about the impacts that will have on everybody. So hospital closures is a really obvious one. The ERs are going to be more crowded now because if people are not getting primary care, they're waiting until they've got a major issue and then going to the one place that will treat them, which is the ER. And so if you yourself who have private insurance, your hospitals will be busier. So I wish everybody cared about people other than themselves, but sometimes people only care about themselves. And so I think it's incumbent on us to always include a little bit about how, despite these folks who have lower incomes bearing the absolute brunt of this, it will impact everyone. If everybody is less healthy, that impacts all of us, even those of us with healthcare. And I also think those stories about, I particularly like doing these maybe local level Republican leaders like mayors and people like that who are seeing the firsthand impacts of this and the kind of balancing act that they have to do in their communities and with leaders at the state level and advocating for people in their communities while also dealing with the political reality of Medicaid in a very very conservative time.
And April, did you want to weigh in on this one, or?
Yeah, no, I think that's a great point. I'll just add that, in places like Jefferson County, for example, the hospital has if the hospital's not there, it has a trickle-down effect. It affects, people leave, they lose population, it affects the schools, it affects whether they can have their prison. So everything kind of is in disarray when we think about a hospital closing.
We have a comment from Melissa Marshall who says, I recommend that the media reach out to disability rights groups, specifically Centers for Independent Living. They are run by and for disabled people and engage in systemic and individual advocacy. Great suggestion, Melissa. And I guess I just want to close by asking all of our panelists about this kind of conundrum, in that the way that some of these biggest cuts were designed, they don't come into play until 2027. And it's kind of like what's going to be barreling toward us, and how can journalists really make people in your state or your audience aware of cuts and changes that might feel distant, or that they might not be aware is coming? What are some of the strategies that all of you might have?
I would be just identifying that range of folks who depend on Medicaid or get their health insurance through the marketplace, and just following them over time to see how the changes are going to affect them. I might also think about what comparisons can be done, like, what does it look like now versus what does it look like some years ago? If you have an archive, go back to those sources, and try to think about really tangible things and drilling down to how that affects people.
Yeah. Anybody else want to weigh in on this one?
Well, as advocates, similar to April, we're looking at tangible things. And for us as advocates in Mississippi, even though we have this laundry list of healthcare needs in our state as a result of not expanding Medicaid, we're looking at tangible issues. And for us right now, it's the enhanced premium tax credits and the impact it's going to have on our community. We've had to parse out some things, and that's front and center for us now.
And Anna Claire, did you want to weigh in on this one at all?
Yeah, it made me think of, I think the way April did her story is a really good, not that people should copy, but a really good framing and looking at, you don't see these changes yet in your area, but a very similar person in a state that has not expanded or that that's going to have work requirements or something like that. Comparing that, that might be a good way to, before all these changes actually hit, show what could be coming down the road.
And a final question to Anna Claire and April, which is, in a way, this isn't so relevant for the reporting that you have done recently because Anna Claire, you're at a kind of wonky policy shop, and April used to be in, one also. But like thinking back, Anna Claire, to when you were at AL.com or something, more general newsroom, what strategies you have to convince editors that these are worthwhile stories or ways into the stories that could get you some time to work on something like this?
For me, it depends on the editor. So, if I know them really well, if I know that they want to hear the data, then I'm going to lead with the data that's going to get their attention. If they're going to be interested more in like the human interest story, then I try to find that source and I lead with that.
I also will sometimes, if it's a story I want to do, if there's any tie to anything currently in the news, editors do love trending topics. And so, if you've got something, a great story, but maybe there's a tie-in to the Maha movement, say, if that's currently in the news or something like that. That's always one way that you can kind of generate their interest if they may not otherwise be interested.
Yeah, well, thank you. Well, with that, I think we'll call a close to our webinar. We've gone a little bit over, so thank you so much to our panelists, April, Roy, and Anna Claire, and to the audience for their excellent questions. I would also like to thank Ryan White, our content editor, and Nadia Lozano Murphy, our communications intern, who are helping behind the scenes. We'll be emailing you a survey asking for your feedback on today's program and for your ideas on other topics of interest. Please take a moment to complete it. We also urge you to follow us on social media and to sign up for our newsletter, which includes information on future events. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us and have a wonderful day.